Welcome to our educational event today. My name is Nan Lei. I'm a faculty member at the University of Texas Southwestern, and I specialize in cornea, cataract, and refractive surgery. And today I'm joined by my esteemed colleague and friend, Dr. William Waldrop. And he's also an expert in the field of cornea, cataract, and refractive surgery. And he's also the fellowship director for our cornea fellowship at UT Southwestern. Today we'll be talking about cataract care today. We'll be discussing technology-driven imaging, sort of evaluation for cataracts, premium IOLs, and the evolving surgical approach. And thank you to MedNet for organizing this event. And also thank you to Alcon Vision, Edmedco LLC, and J&J Vision for supporting this event in the form of grants, educational grants. And again, this is a continuing medical education event. So in order to get your certificate, please attend the entire webinar. There will be a brief evaluation at the end of at the conclusion of the program. And then after that, there will be a link for you to download the certificate. And please try to get this completed by October 18th. Here's just a disclosure about unlabeled use. We won't be discussing any off-label drugs. Here's a disclosure about financial relationships. And just to summarize, Dr. Waldrop, myself, and the planners of this event don't have any relevant conflicts of interest to report. So today I'll be giving a talk. First, I'll be discussing overview over the types of cataracts, preoperative and intraoperative imaging in cataracts, as well as some of the recent innovations in cataract surgery. Will then give his talk about discussions about the innovations in cataract surgery, and then really how we can utilize this and wield this in order to improve visual outcomes and safety outcomes. And then at the end, we'll have a 15-minute panel discussion. And please feel free to ask any questions. We're happy to discuss any sort of clinical topics. So we'll go to our first pre-test clinical vignette. We have a 70-year-old male patient who has undergone previous radial keratotomy. He has a highly aberrated cornea, and after a thorough discussion, he decides to undergo cataract surgery, and he's interested in having a monofocal intraocular lens. So which intraocular lens would induce the least amount of aberrations? We have A, the J&J Eyhance lens, B, the Alcon Acrosoft lens, C, the Bausch & Lomb Invista lens, or D, the RxSight light adjustable lens. And the poll should be up. Hopefully everyone can see it. Looks like the field is pretty split here. So I'll be discussing this during the talk. So I'll go straight into the talk here. So again, I'll be covering a review of lens anatomy, the types of cataracts. I'll be discussing preoperative and intraoperative imaging when it comes to cataract evaluation and cataract surgery planning. And then I'll be discussing innovations in cataract surgery as well. So to start us off, I want to talk about lens anatomy. It's a biconvex avascular structure composed of epithelial cells. And by dry mass, it's actually the structure in the human body with the most protein. So it's a pretty incredible structure. It can change shape dynamically in order to account for accommodation. And over time, these protein will break down due to oxidation, UV exposure, cellular damage, and eventually will pacify and become a cataract. So let's go ahead and kind of do a brief review over the different types of cataracts. We have congenital, we have age-related, traumatic, or cataracts that are secondary to systemic diseases, ocular pathology, and drug use. So this first image here, this is an image of a Morgagnonian cataract. This is a hyper-mature cataract where the cortex has completely liquefied. And now in the core, you have this very dense mobile nucleus These cataracts can be very challenging because sometimes the capsule can be extremely fibrosed, and typically you'd expect some level of zonulopathy in these cases, or sometimes a significant zonulopathy. This here is a congenital cataract. Specifically, it's a lamellar or zonular cataract. And in this case, there's opacification of just one layer of the nucleus, and it leads to this sort of interesting kind of a stunning appearance of the cataract. This is an ultrasound of the anterior segment. This is a UBM showing anterior capsule violation and leakage of lens material. So this is typically urgent because this can cause a phacoantigenic glaucoma, where the immune system responds in a sort of granulomatous reaction to these lens proteins and can cause a pretty severe intraocular pressure spike in glaucoma. Uh, This most of us would recognize as a Christmas tree cataract. There's sort of these polychromatic opacities, and the most common association is with myotonic dystrophy. This is something we see in the textbook often. I think a less common association that we tend to forget about is hypoparathyroidism. So when you see this in a patient and they don't have myotonic dystrophy, really this should be worked up. These patients should get a calcium level and a parathyroid level. This is a cataract with Glaucomflecken. So this is what happens whenever patients have acute angle closure or pupillary block. You get these necrosed epithelial cells on the center of the cataract here. I don't know if you can see my mouse, but I'm kind of pointing to it here. You get iris atrophy from the angle closure, and oftentimes these patients have zonulopathy as well. Um, After you see a patient with a cataract, it's really important to get preoperative imaging. And even more important is trying to optimize the ocular surface so that we can get high quality measurements. If you can optimize the ocular surface and get good measurements, well, then you can really maximize the refractive outcome that you can deliver for these patients. So if the patient has dry eye, I'm very aggressive about treating the dry eyes and epithelial keratopathy. If the patient wears contact lenses, whether it's soft or hard contact lenses, I do a good contact lens holiday. If the patient has a pterygium, I'll often consider removing the pterygium, waiting a few months for the cornea to stabilize, and then repeating measurements for cataract surgery. And if they have EBMD or epithelial basement membrane dystrophy, and the epithelium is very irregular, sometimes we consider debriding this first or doing a superficial keratectomy. So in terms of the preoperative imaging we'll be discussing today, I'll be discussing topography, tomography, aberrometry, biometry, and some posterior segment imaging as well. Now, regarding corneal topography and tomography, the reason why this is important is, well, one, if you're a refractive surgeon and you're using toric lenses, it's really important to understand what the astigmatism looks like. Toric lenses can correct regular astigmatism. If the astigmatism is very irregular in topography and the patient vision doesn't improve much with a manifest with cylinder, oftentimes the toric will not help this patient. But just kind of going over the types of topography we have. So the first thing we had was a placido disc. A placido disc is based on reflections of concentric rings off the cornea. These reflections are then analyzed and you get information about just the anterior surface of the cornea. So you don't get any information about the posterior surface. You don't get a 3D image of the cornea. Next, we have a spectral sweep OCT. This uses low coherence light. And in this case, you do get 3D images. So you have information about the thickness of the cornea, the anterior and the posterior surface. Scheimpflug uses a rotating camera, and again, this creates a three-dimensional image. So you get information about anterior surface, posterior surface, you get elevation maps, you can get pachymetry maps as well. Wavefront analysis utilizes a sort of mathematical model called a Zernike polynomials, and this helps us to understand how aberrated the cornea is. And this is really important when you're thinking about whether a patient would be a good candidate for something like a multifocal lens. And then the newest systems of topography really combine all these technologies in order to maximize the amount of useful information we can get clinically. And next, I want to talk about correcting astigmatism, and specifically, correcting astigmatism at the time of cataract surgery using toric lenses. So I've created a sort of really basic algorithm for this. This is in no means exhaustive. And a couple guiding principles. We know from prior studies that patients with three-quarter diopters or more of astigmatism can notice this, and it really affects their visual quality. We also know that eyes slowly develop against the rule astigmatism with age in general. There are exceptions to this, of course. And then the other thing is, if we know patients become against the rule with age, having a little bit of with the rule astigmatism can be beneficial. So the first question I ask myself when I see a patient with astigmatism is the astigmatism regular or irregular? If it's irregular, I need to find out why. What's the etiology of the irregular astigmatism? And this can be a wide range of things, but I kind of break it down into some simple categories. Is there ocular surface disease? Is there some sort of dystrophy like epithelial basement membrane dystrophy or Salzmann nodular dystrophy or degeneration? Is there ectasia? Does this patient have pellucid or keratoconus? Or is there a scar or opacity that I'm missing on the exam that is causing this astigmatism? So when it comes to dry eye, again, you need to optimize the surface, and then you can reevaluate if this patient could be a good candidate for a toric lens. If it's EBMD and they have very irregular astigmatism, you could consider debridement. Now, if there's a scar or opacity that cannot be corrected, oftentimes a non-toric lens may be better in this case. Now, ectasia or keratoconus, this can be a little tricky. I think the general teaching is that these patients should get a non-toric lens. But I would argue that there are some special scenarios where these patients can really benefit from a toric. So for me, if the central 3 or 4 millimeters of the cornea has very regular astigmatism and the patient's vision improves using a manifest with a cylinder power, that may be a patient that can really benefit from a toric. Now, if the central cornea is too irregular, then yes, a non-toric lens would be a better choice here. Now, what happens if the astigmatism is regular? Well, if the patient has with the rule astigmatism and it's under a diopter and a quarter, typically I wouldn't use a toric lens here because T3 power toric lenses would overcorrect this. You'd end up giving the patient against the rule astigmatism. But you could consider corneal relaxing incisions in this case. Now, if it's over a diopter and a quarter of with the rule astigmatism, I will go ahead and use a toric lens to correct the astigmatism. And my goal here is to leave them with a little bit of with the rule at the end. I don't want to flip them to against the rule because, again, patients will become more against the rule with age. If it's against the rule, I'm much more aggressive. If they have 3/4 diopters or more, I'll go ahead and place a toric. If it's under 3/4 diopters, you could consider a non-toric lens, but using corneal relaxing incisions. Next, I want to touch sort of the basics about higher order aberrations. And I'll really just be sort of skimming the surface here. This won't be covering this in too much detail. I want to kind of highlight the Holiday report. So the Holiday report, also known as EKR 65, Dr. Holiday created this report to help with IOL calculations. And EKR 65 sort of means that Dr. Holiday took the weighted mean of the 65% of the corneal power in the central 4.5 millimeters. The reason why 4.5 millimeters is this is sort of the average mesophic pupil size. And there's a lot of numbers on this report. I won't be talking about all these and what they mean, but I want to highlight a couple and how I use these clinically when I look at patients with cataracts. A couple principles about this before we go into it, the average corneal spherical aberration is about plus 0.27, and the young crystalline lens has a negative spherical aberration. So this sort of accounts for the corneal aberration to help reduce the overall spherical aberration. You can use this to your advantage when it's time for cataract surgery as well. If you know the patient's spherical aberration, you could choose an intraocular lens that can help negate some of that spherical aberration. So most intraocular lenses induce negative spherical aberration. So, if you have a patient who's undergone myopic LASIK, which induces positive spherical aberration, it may be beneficial to use a lens to counter some of that. Conversely, if the patient's had hyperopic LASIK, that induces a negative spherical aberration. So you might want to go with the SA60AT lens, which induces some positive spherical aberration. Now, if the patient just has a very aberrated cornea and you're just wanting to sort of reduce the aberrations as much as possible, the Bausch and Lomb lenses, the Invista, the Acryos, those do not induce any spherical aberration. So those have a neutral spherical aberration profile. And again, that's sort of the MX60 Invista lens from Bausch and Lomb. So going back to the holiday report here, some of the numbers that I want to highlight. One is the root mean square higher order aberration. So what does this mean? This value here is giving us an estimate of the total corneal irregular astigmatism. And ideally, I want this to be less than 0.6 in patients where I'm considering a multifocal lens. So multifocals, optically are sort of dividing up the light so that we can grant patients a range of vision. Now, there's a risk of glare halos with multifocals. And if the patient also has a very aberrated cornea, this is going to sort of compound the issue. These patients can be really unhappy with this lens, and these lenses may perform not very well in these eyes. So for me, this number I like to see under 0.6. The next one here is sort of total corneal higher order aberrations. This is in sort of the 4 mm zone. Now we know that if the higher order aberrations are 0.3 or more, this can lead to a defocus of about 0.5 diopters. So ideally, I like to see this under 0.3 microns when considering a multifocal for patients. Next, we'll talk about intraoperative imaging. So we discussed what we get prior to surgery, but there's actually some intraoperative imaging that can really help us with surgery. The first we'll discuss is sort of imaging overlay to help with toric alignments. So we can put in torics to correct regular astigmatism, but we have to align them at a certain axis. And using this sort of digital system can help with efficiency and actually help improve outcomes as well. We have intraoperative OCT. This can be useful in a variety of manners. This is an example of using OCT intraoperatively when looking at a white cataract. And here you can see sort of these clefts under the anterior capsule. This is indicating that this lens may be very intumescent and might need decompression prior to cataract surgery. You can use OCT to also confirm your hydrodissection or hydrodelineation. And here you can see there's a fluid space between the nucleus and the epinucleus. You can use it to look at corneal wounds. You can also look at it, use it to evaluate the posterior capsule. So in cases of a posterior polar cataract, sometimes this capsule is not intact, and it'd be great to know that before starting phacoemulsification. This is a cataract that developed after intravitreal injection. And you can see here on the OCT that the posterior capsule's already been violated. So this will totally change how we manage this surgically. And we have intraoperative aberrometry. We use the aura, which can help guide us on selecting IOL power intraoperatively. You can use this and sort of compare it with your preoperative measurements to see if they agree. And next, we have the 3D heads-up display. So this was designed to improve ergonomics and to reduce the risk of neck strain or neck injury, in people who are doing surgery for many, many years. This is really important. So I want to talk about marking for toric. So, traditionally we would manually mark these patients. We would see them in the preoperative area. We would set them up and mark the 0 and 180 degrees. That way we could then align the toric lens during the surgery. But there's modern techniques now like the imaging overlay, or you could even use femtosecond laser to mark where the toric needs to be aligned. So you and colleagues did a study. They looked at four randomized control studies, over 200 eyes, and they compared the digital overlay system with manual marking. And they found that the digital overlay system had a lower risk of post-operative IOL misalignment. Schultz and colleagues took this one step further. Instead of comparing manual marking with the digital overlay, they compared femtosecond marking with the digital overlay, and they found that the femtosecond laser was actually more precise and had a lower risk of misalignment. Perhaps the femtosecond capsule marking may be the most superior method we have currently. However, that doesn't mean digital overlay or manual marking is bad. You can still get very good outcomes with those methods. So next I want to talk about the intraoperative aberrometry, or ORA. There's a couple clinical questions here which I think are really important. And Pantanelli and colleagues, their question in their study was, how does the ORA compare with our traditional IOL calculations? Well, when looking at eyes that had never had prior refractive laser surgery, the ORA was pretty similar to the Barrett Universal and the Hill RBF, and it was superior to the older, more standard calculations. Now, when looking at eyes that have had refractive laser like LASIK or PRK, the ORA was similar to the Barrett TrueK, and it actually outperformed all the older formulas. Well, another clinical question a lot of people have when thinking about the ORA is, what happens when the ORA disagrees with your preoperative measurements? Which one should you go with? Should you go with your measurements, or should you trust the ORA? So Greenwood and colleagues did a study looking at 281 eyes, and they found that when the ORA and the preoperative measurements did not agree, selecting the ORA when it recommended a higher power actually led to improved outcomes and fewer hyperopic surprises. So clinically using this might be a scenario where you go with the ORA over your calculation. Nicole Fram and colleagues did a study as well, similar to the first study I showed here. And I highlight this because they got a different result. So in the prior studies, the ORA was similar to the Barrett TrueK. Actually, in Nicole Fram's study, she found that the ORA outperformed the Barrett TrueK when looking at post-myopic LASIK. So again, maybe this is a scenario where you really want to use the ORA in your post-LASIK cases. And finally, I'll kind of conclude with current innovations. With the current innovations, we can really improve our preoperative and intraoperative imaging modalities. This leads to, hopefully better refractive outcomes and better safety. We have advancements in microscopes. We have advancements in intraocular lens options. We have more refined phacoemulsification systems and femtosecond systems. And we even now have a way of doing cataract surgery without using phacoemulsification at all. And that's the MyCore. I'll briefly go over all these. So the 3D heads-up display, there's a camera on the microscope. This projects a 3D image actually onto a screen. So you can actually look straight ahead while doing surgery without having to look down and bending your neck. This improves ergonomics. This can also be integrated with overlay systems to help align toric lenses. And then the other benefit is this allows for team viewing. So if you have residents and fellows, or even just your scrub technician, it's really easy for them to follow along the surgery. There was a study done by Nature, and they actually found that using the heads-up display improved the neck angle and reduced the risk of neck injury or neck discomfort in surgeons. I want to talk about some of the recent IOL innovations here. So we have the Althera lens. This is a hydrophobic acrylic lens. The interesting thing about this lens is there's sort of an optical zone here. You can see there's sort of a dark ring and then a central optical zone. The benefit of this is, well, one, this gives you some extended range of focus. The other benefit that some surgeons are using this for is using this lens in patients with very aberrated corneas. Let's say a patient has 16 cut RK. Um, there was a study kind of comparing the Athera lens with a monofocal lens, and they found that patients had improved depth of focus with the Athera lens. And now the downside was that there was more visual phenomena. Some patients with this Athera lens notice a sort of darkening of their vision. And next, we have the light adjustable lens. This lens has really kind of revolutionized what we can offer to patients. This is a lens that you can implant, and then using a UV light delivery system, you could adjust the shape of the lens. You can correct up to, adjust it up to 4 diopters on a spherical plane, and then up to 3 diopters for the cylinder power. So in patients who've had, refractive laser, history of myopic LASIK or hyperopic LASIK, I think this is a really good option because our IOL calculations traditionally don't do justice. There's more room for error. But with the light adjustable lens, really we can maximize what we can offer these patients refractively. So this has been really helpful in my practice. We have new multifocal lenses coming out every year, it feels like. J&J comes out with their Odyssey lens. Alcon has recently come out with the PanOptix Pro. So with these lenses, often there's promise of fewer aberrations and a better range of vision. We have new phacoemulsification systems. So Alcon's Unity, this is a system that can also perform vitrectomy. So it can do anterior segment and posterior segment surgery. The Stellaris is from Bausch& Lomb. This uses Venturi fluidics, and this can improve sort of AC stability and can really help in surgery. The J&J Veritas I've never used before, but it uses both peristaltic and Venturi system. And it has a very customizable phaco tip. So for surgeons who really like to be able to customize their surgery, this may be a good option. The Zeiss Quaterra uses a sort of quattro pump fluidic system to improve anterior chamber stability. And I'll briefly touch on this, but the new system for cataract extraction, this is from Zeiss. This is called Mycor. So it's very different from what we're used to. This does not use any ultrasound energy. It's all sort of a mechanical breakdown of the cataract. There's also no foot pedal. It's totally controlled by this sort of finger throttle that you can see in this image here. So without ultrasound energy, there's no heat generated. There's no chance of a wound burn. And their hope or their thought process is hopefully it's also more gentle on the corneal endothelium. I'm not sure if this has been shown yet in studies. Also, there's no machine setup. So there's much less equipment costs. It takes up much less space in the OR. I've used the Mycor. I've done maybe 30 to 50 cases with it. I would say the downsides include the learning curve. It's so different from phacoemulsification. After 30 to 50 cases, I just started to feel comfortable with it. And the other downside is, maybe it's not as versatile. There's less settings on it that you can adjust. But of course, it's still a work in progress. Now, innovations that are on the horizon, I think sort of the holy grail for intraocular lens options would be a truly accommodating IOL. And there's several that are sort of in the works currently. Optimization of AI and lens formulas, and also robotic cataract surgery. All these things are on the horizon. So I won't discuss all these sort of accommodating lenses in detail. I'll kind of group them together. But these first three lenses by Alcon, LensGen, and Atia Vision, they all kind of work in a somewhat similar mechanism. These lenses are implanted in the capsular bag, and whenever the bag senses compression, this leads to a sort of change in the lens shape that can mimic accommodation. This last lens here is different, though. This is a hydrophilic lens designed for implantation in the sulcus, so not in the bag, but in the sulcus. And here, the lens can sense ciliary muscle contractions, and then this is what drives the shape of the lens to change. So this is what our multifocals try to mimic. They try to give a range of vision to try to mimic accommodation. But if we could have a truly accommodating lens, this might be sort of the best option, but definitely still a work in progress. And then a very recent thing, this is just October of 2025, Horizon Surgical Systems completes the world's first robotic assisted cataract surgery. So they have this system that combines artificial intelligence, digital imaging, and real-time OCT that can sort of provide a 3D image of the cataract while you're doing surgery or while the robot's doing surgery. And also, this employs machine learning. So this is just going to get better the more data and the more information the machine has over time. And of course, the machine has no tremor. It has a vastly improved reaction time and vastly improved precision when compared to human hands. So you may have already seen this, but Uday Devgan, who's cataract coach, is a part of this, and he was sort of the surgeon that helped with the first cases for robotic assisted cataract surgery. So this is something that maybe closer on the horizon than we think. Probably within the next few decades, we'll be seeing robotic cataract surgery, which will really kind of revolutionize the field of ophthalmology. So just to summarize sort of the key points here, we have all these advancements in imaging, calculations, instruments, and this can really help us deliver, improve patient outcomes. Optimizing the ocular surface is crucial to sort of maximize our measurements and our outcomes. We can use intraoperative imaging and overlay systems to help us. And also the final part, sort of AI, machine learning, robotics. These are really sort of coming to the doorstep here. Thank you all so much for your time. We'll go back to the clinical vignette here. So again, we have a 70-year-old male patient who's undergone prior RK. He has a very aberrated cornea, and he elects a monofocal lens. So again, which intraocular lens induces the least aberrations? We have the J&J Eyehance lens. We have B, the Alcon Acrosoft lens. We have C, the Bausch & Lomb Invista lens, and then D, RxSight light adjustable lens. So we'll put up the poll here. Right, so we have a higher proportion of the correct answer now, which is C. So the Bausch & Lomb Vista lens, this really has a neutral spherical aberration profile. So really aberrated corneas, you would consider using this lens. All right, well, I'll go ahead and pass it over to Dr. Waldrop here. I'll go ahead and stop sharing screen here.
Well, it's great to be with you and follow up Dr. Lay. Um, you'll notice we touch on some similar topics. It's really nice to hear his perspective on a lot of this, and I'll give you mine, of course, with a few kind of extra details, maybe a different way of kind of reviewing some of this. We'll start with a vignette on my section here too. So our first case here is a 65-year-old woman who has a history of pseudoexfoliation, normal IOPs, and no changes on her RNFL. She comes in for cataract evaluation and is obviously wanting you to consider the best IOL strategy for her eyes and the technique for removing her cataracts. Which of the following statements regarding phacoemulsification fluidics is most correct? So a classic board exam style question, the most correct answer. We have longitudinal ultrasound reduces chatter. Active fluidics destabilize intraocular pressure. Lower cumulative dissipated energy is associated with better endothelial outcomes. And surge control is least important in dense lenses. Give you a second to look through that, try and pick the most correct answer, and we'll see what people come up with this time around. Okay, so a little bit less of a I think Dr. Lay's question was great because the first time around there was lots of lots of debate, and this time we have a little bit of a spread. So we'll see if answers change over the course of this over this talk. So in this portion, we're going to talk about optimizing visual outcomes and safety. And really, just to highlight here, I like this very basic image of two surgeries kind of coming together, both having tip of the spear kind of refinement that we seek in eye surgery, and particularly surgery to correct vision. And really, of course, as you all know, cataract surgery is really a refractive surgery now, as Dr. Lay laid out too, the ways that we think about um, imaging eyes before cataract surgery, the ways we think about refining our techniques of surgery, just and the different types of lenses we use have squarely made cataract surgery refractive surgery, and those spear points are both have both been sharpened and are really in close apposition. So they're really the same. In this portion, we're going to talk specifically about advanced phaco and fluidics. We're going to talk about modern IOL technologies. We're going to assess intraoperative equipment, some of the evidence, and summarize that, and apply to a few somewhat complex but definitely real world type cases, and then answer some of your questions that may stem from that discussion. So, what about advanced phaco and fluidics? So, the technologies that have progressed recently in cataract surgery are still phacoemulsification technologies that include what's called active fluidics. We've improved the way that ultrasound is delivered, and specifically torsional ultrasound has changed how effectively a phacoemulsification device removes the cataract. And there are newer devices too that have included what's called a fourth dimension or a 4D approach to removing cataract with ultrasound, so that the handheld device you use moves in more directions than even just three dimensions. It moves in space and in a certain um, pattern that helps reduce the energy um, that's used to remove a cataract. There's also both real-time intraocular pressure control, and of course, again, those fluidics help stabilize intraocular pressure, which also allows surgeons to reduce the eye pressure to their liking. So one of the things surgeons can do in order to reduce post-op edema is to operate at a lower pressure, and newer systems allow more surgeons to do that. It's not a requirement for good surgery, but it is an option um, to use a lower pressure system. Another thing that helps preserve the endothelium and reduce corneal edema is using less energy overall. So that's definitely a key principle. And surge control is one of the ways that systems help more efficiently remove dense cataracts. And the denser the lens is, the more important that is. Complication rates um, with the newer systems are actually pretty similar. Of course, this depends on the experience of the surgeon. So, fortunately, cataract surgery has a very low complication rate overall, especially with experienced hands. The systems um, do help with that, but we're already talking about surgery which has a low absolute complication rate. There are some evidence gaps. Certainly we can improve the number of large randomized controlled trials, and the ones that do exist, of course, are kind of differ in terms of patient populations, surgeons. So we're always striving to improve in terms of the science behind this. What about the non-phaco lens removal systems? It's good to remember there are other systems other than phaco. One of them, which I know Dr. Lee is actually very skilled at, is making a scleral tunnel, so-called manual small incision or M6 cataract surgery. Um, this is a technique which qualifies certainly as old school, and is for the densest of cataracts. When he showed you a picture of one of those Morgagnian cataracts, sometimes that's a cataract that surgeons will approach with a manual small incision in order to remove safely. But the reality is modern phaco devices, you can still use them and you can still use an approach with them to get out a cataract even that bad. Um, One of the best applications of manual small incision cataract surgery is in places that are not resource rich. So places abroad, outside the United States, frequently where surgeons will use this technique, and that offers some specific advantages in that setting. One of the downsides of modern phacoemulsification getting so good is that trainees learn this technique less and less. So that is a phenomena that is continuing. I do have a colleague who frequently makes the incision he would use for a manual small incision on a cataract to just to maintain his skills because he can use phacoemulsification so often to get cataracts out, and he needs to maintain skills. So when he goes abroad, he can use the M6 technique that he is also skilled at. Femtosecond laser assisted cataract surgery for sure is a technique that does incorporate phaco removal. Um, and is somewhat separate, but it's good to note that laser-assisted cataract surgery is improving all the time too. We'll talk a little bit more about that in a little bit. And then Dr. Lay touched on and obviously described his own personal experience using the Nulex or non-ultrasonic lens extraction device, and that's a really unique one. I've only used it in a lab, um, and I think that device has some particular applications. What about modern IOL technologies? Let's talk a little bit more about um, those lenses that we use. Certainly, they've come a long way over the years, and I think in many ways, the way that these lenses have been re-engineered, we go forward and backwards a little bit in terms of thinking about lenses. On the left here, you see a crystalline lens that was designed to be accommodating and is still um, a lens that's out there, but it has not been a lens that worked as well as we hope. So accommodation, as Dr. Lay touched on, is something we're still seeking in terms of a lens. We've largely focused on changing the optics of the central optic of the lens, so that central round portion, whether it's through diffraction or refractive techniques, or even having a lens like the light adjustable lens shown at the bottom, which is a three-piece UV light adjustable lens. Generally, the ways that we improve IOL technology the most recently has been altering that central portion and making that central portion of the lens alterable in the postoperative period while the lens is in the eye. So what about these overall modern IOL technology? How do you fit this into a practice? How do you conceptualize these lenses? Well, um, I think it's really important to have a grip on basically all of them because they all, as you will see, and Dr. Lay alluded to, will come in handy in certain patients. Um, and deploying certain lenses, even certain brands of lenses, in a specific patient is probably one of the most important things that a cataract surgeon does. Going right down to that very simple question that he proposed, um, which is which of these lenses would you use, in this scenario? So having not only a grip on all of these different options, but knowing what company's lenses to use within each of these categories is really important. I mean, I think the four main things that maybe are most important in an IOL strategy framework is to try to match the optics of a lens with a patient's lifestyle. And sometimes their lifestyle is largely based on their baseline refractive error too. What are they used to? Are they, simple questions about a patient's eyes based on their level of hyperopia or their level of myopia. What is that patient used to in terms of how they use their eyes, how they use their glasses? Um, I think in general, patients who are low to moderate myopes are some of the most challenging patients to impress with a lens, particularly a lens that's designed to give them distance and reading vision, because their reading vision is pretty darn good. Sometimes even with a moderate or even severe cataract, they've maintained really good reading vision. So impressing them with a lens that gives them better distance vision, but doesn't give them quite the same reading vision they're used to, can be a real challenge. And that's where the last thing comes off in terms of counseling on trade-offs. Um, you have to be open with patients about what they may be seeing afterwards, recognizing that no lens is perfect in terms of delivering a full range of vision, and having a clear discussion with them about what's most important to them and what they may be able to experience after surgery. And of course, it's very tough to automatically tell them what they're going to see after surgery, but having a good sense of what they're used to, the types of activities they do, and thinking about that is really important. The other thing is being appropriately conservative. So when there's pathology present, and you can pretty much say any pathology in the posterior segment, but pathology that could limit contrast sensitivity down the road, you don't want to use a lens that may impact that right after surgery, and in anticipation of that becoming more of a problem. So the classic scenario is a patient with very fine drusen in the eye, and their mom had a history of macular degeneration that worsened in their 80s, and they're coming to you for cataract surgery in their 60s, and they see 20/20, and their visual potential is high, but they have macular drusen. How do you consider what lenses to use? And there's ultimately no absolute right or wrong answer to that, but I think trying to preserve contrast and thinking about lens strategies that do that, i.e., non-diffractive lenses, is the way I typically go with patients. You also need to aggressively treat the ocular surface. So Dr. Lay alluded to this, and he had a great um, way of kind of thinking about the cornea, imaging the cornea, thinking about higher order aberrations, thinking about what are the ways to optimize the surface. Um, and really, you need to do something. Most patients will benefit from some treatment, and certainly other patients need a lot more. And I think also being realistic. If you find out that a patient is not able to do that, you need to be realistic with the patient about what lenses may be good options. Again, patients who cannot treat their ocular surface well and have irregular corneas will have irregular outcomes with lenses that employ diffraction, lenses that try to bend light in such a way that the cornea is not going to be kind to their vision. So I think being realistic in that case is important. Of course, even in patients who have totally normal corneas, have never had refractive surgery, you have to counsel them on the potential for different visual phenomena after surgery. Now, we've all had patients that have had any number of visual phenomena with any number of lenses, and that's why it's so important to match the lens with the patient. But um, I mean, my approach to counseling patients is to mention the possibility of glare and halos really with any lens, but in particular with diffractive lenses, which are the more common kind of multifocal lenses. You see here some of the different images that may be more specific to certain types of lens technology, but the reality is you can see different visual phenomena with all these lenses. Some patients, when you have that discussion, they're quite adamant this is not what they want in their vision at all. And it's quite easy for them to be honest about that with them, both you and with themselves. Sometimes it's hard to draw it out. One question I've learned to ask for certain patients is asking them, "Hey, when you have your windshield cleaned in your car, is it sufficient to let them clean the outside, or are you going back in with Windex to clean the inside portion of your lens to make sure it's spotless?" It's not a perfect question, but it gets at the point. How adaptable are you, and how tolerant are you of relatively minor imperfections that may be apparent with really any lens you use, but particularly certain lenses. And I think you have to be very clear with patients about this possibility. Other major thing is that correcting astigmatism matters a lot. So some of y'all may have noted that Dr. Lay has a pretty low threshold for correcting astigmatism. I think correcting astigmatism is super important, and the opportunity to correct astigmatism may be the most impactful thing we can do with cataract surgery. That simply gets heightened if you're considering an advanced technology lens. So certainly a lens where the optics employ diffraction, or you're trying to use an enhanced depth of focus lens, you need to nail their astigmatism. You better get it as close to zero as possible to allow that patient to see. And we see here, as you all know, any amount of stigmatism can blur vision, but it doesn't take too much um, to impact vision. Uh, and of course, if you're not confident in the ability to correct someone's astigmatism, i.e., irregular astigmatism, then it'll be really hard to make any lens work to give a patient a range of vision. Advances in the outcome of a surgery really depend, I think, on correcting astigmatism, and this, of course, can really make the difference in the patient's outcome with surgery overall. Some of the ways we do that include employing iris registration, using intraoperative aberrometry, improved visualization systems, and also laser-assisted platforms. I'll talk to you about each of these. So, as Dr. Lay mentioned, one method of correcting astigmatism is to use manual markers. You gotta numb the eye. You gotta touch the eye with an ink marker. Takes extra time. There's some extra potential discomfort, and the alignment is not nearly as precise as it is with iris registration, which allows a digital marker based on a preoperative photograph aligning with an intraoperative photograph to then keep track of the axis of astigmatism. Um, and there are ways that this registration can even be enhanced and incorporated with laser-assisted technology. There's even a new laser-assisted technology which makes a mark on the capsule, which is basically at the plane of the IOL, which makes a whole lot more sense than making a mark physically outside the eye, which is really nowhere near the plane of the IOL. So capsule marking is a new innovation in laser-assisted cataract surgery that can help. How much does this help? In general, image-guided systems can improve toric alignment by somewhere between 2 and 5 degrees, maybe more in the right hands, depending on the right scenario. So data is not super clear, and even in best of circumstances, maybe that rotation is not super high. But 5 degrees in cataract surgery matters. So um, I think I think in general in my practice, I really like using a digital marker, some technique other than manual marking to assist. Another way to assist in toric refinement is with intraoperative aberrometry. And so this is a system where the eye is measured after removal of the lens. So in an aphakic state with the bag filled with a viscoelastic, you measure the eye. It's certainly helpful for a post-refractive eye. I find it not as helpful for RK eyes because those eyes tend to have changes that make it hard for the typical intraoperative system to read the eye, but it's definitely useful for toric refinement. In routine eyes, data suggests it's not as impactful, and it's definitely an adjunct and not a cure-all. One way that people can use this, of course, is like I mentioned in toric alignment. It does give you a recommendation and allows you to align a lens better. So you put the toric lens in the eye and do a second measurement, and this allows you to determine what's a live read of the astigmatism over the whole visual axis. And it gives you a recommendation on which direction to move the lens. These measurements are somewhat finicky, and figuring out the pitfalls and the accuracy of these measurements takes time. So things like corneal edema, centration of the capsulorhexis, adequate pressurized eye to do this reading really are key in making aura a helpful part of your um, uh, surgical repertoire. So, like anything, high learning curve can be frustrating early on. So, taking the extra time to align a lens and do extra measurements is not always what people want to do. But if you learn these techniques and grow with these systems, I think they really have a place for, in particular, aligning astigmatism correcting lenses. Improve visualization systems. So Dr. Lay talked about the three-dimensional viewing system we can use. It has enhanced clarity modes. It has overlays that allow you to um, better image the capsule. So we've shown here doing a case that it actually has trypan blue, but this is a much enhanced visualization of the trypan blue for a dense cataract. Um, and so the three-dimensional system helps with that. overall, the data suggests that there's certainly equivalent safety, but maybe an ergonomic benefit. And Dr. Lay also mentioned the potential benefit of a 3D system helping with the collective experience. That also may allow for an easier recording of the surgery for learning from that. The ergonomics are important, just like aligning the um, microscope for cataract surgery, you have to align the system to use this. And I think there's potential for really improving the way this works with something like a headset, which may even veer towards kind of a virtual reality setup. What about the laser assisted platforms that we use to improve cataract surgery refinement? So here's an example of a system in the overlay that you can see from a surgeon's view after laser has been deployed on an eye and prior to cataract removal. You have this kind of fighter pilot view of the eye, which follows the patient's eye as you do the surgery. Here's a view of the actual system, which employs an OCT to allow you to align the incisions that the laser is going to make, both on the capsule. You put the marks on the top of the capsule and the bottom of the capsule. It also allows you to precisely set the depth that the device is going to start to break up the nucleus of the cataract. So very another way of employing intraoperative OCT, and the laser assisted platforms are improving all the time. Again, I mentioned the capsule marking system, one major improvement that's done with that. So one summary of laser assisted platforms would be they may improve tolerance of the procedure. So I think frequently patients will report less sensitivity after the surgery. Um, Maybe some increased redness. There can be a little bit of subconcheme that comes from the laser suction on the eye, but maybe an improved tolerance. Did not increase safety, so there's really been no study that suggests, somewhat frustratingly, that laser-assisted platforms do not increase safety, and they might increase the surgical time. Um, Sometimes refractive precision offsets the increase in time. So that's really a surgeon-specific determination, and there's definitely a significant learning curve. So there's nothing like being frustrated by an issue with a laser assisted surgery. So if you feel like the laser was a reason for something going wrong, man, that's going to be tough to adapt to using that laser. In the same way, I'm sure the doctor using that robotic platform, man, if we have an issue with the robot, you're not gonna want to use the robot ever again. But the reality is that once you get through some of the learning on that, it can definitely help. How about some real world scenarios? So I want to bring it home to a couple of cases, and hopefully that'll feed some discussion here at the end. So how about our classic post LASIK patient? Specifically, let's say a history of a myopic LASIK. Maybe they have unreliable keratometry. Maybe they have some aberrometry, um, or maybe they have some higher order aberrations that we picked up on as well. Maybe we're unable to find anything with the cornea that's wrong, other than the simple fact that they've had LASIK. So, what are the ways we can improve their surgery? Well, I think this is a great patient to consider aberrometry in intraoperatively. You're going to use the most modern formulas. Discussion about monofocal versus LAL in these patients. I'd say for a patient, maybe if they had myopic LASIK and they particularly tolerated monovision really well, LAL may be best because it offers a level of precision that they probably need in order to recreate their monovision to their liking post IOL. Whereas if that's not the case, a monofocal lens with aberrometry may be exactly what they need. Recognize that LAL is a lens that is really approved for astigmatism correction. So in a patient that um, may have low amounts of astigmatism, technically the LAL would not be indicated. But of course, we use LAL frequently for patients that have relatively low amounts of astigmatism because it offers us the tailorability of that lens. So definitely, most patients who have myopic LASIK, I'm thinking about a monofocal, maybe specifically thinking about a lens where the aberrations or the higher order aberrations are minimized, or maybe perfectly complemented by that lens's platform. Dr. Lay alluded to some of the lenses that we use. What about cases of high astigmatism? So, we know that correcting astigmatism is important. What about a case where you have, greater than 2.5 or more diopters of astigmatism? So, I think we're thinking mostly about toric lenses. So, those are patients where simply correcting their astigmatism may make the biggest difference. And it may be easier to do that with an astigmatism correcting lens. One key point about LAL is it's not indicated for patients who have more than 3 diopters. And I've found that even patients who have more than 2.5 for sure, it can be tricky to get the patients to the result you want with a light adjustable lens. I think a toric lens, particularly if the astigmatism is regular and all the other measurements look good, is really just what the doctor ordered here. Certainly, I'd like to use axis conformation intraoperatively. I specifically use aura on these patients. And another point about surgical approach, you really want to try and minimize rotation. I think all the different companies have different features of their lenses that help prevent rotation. And in a specific surgeon's hand, they may like a certain lens model. The bottom line is you got to minimize rotation, and I think you got to remove viscoelastic from behind the lens to help ensure minimal rotation of that lens. What about a case of a patient who really wants spectacle independence? So your classic premium IOL candidate, they come to you, essentially demanding this. Certainly, wanting to make sure they have a visual system that actually can deliver on that. And these are the patients where you have a really in-depth discussion about trifocal, multifocal versus EDOF. You think about what their baseline refractive error is. Hyperopes tend to adapt to almost anything, particularly if it's a low amount of hyperopia without a history of strabismus or a high angle kappa versus myopes. You may have to have a very pointed discussion about the trade-offs and realistic expectation about still the chance of wearing reading glasses and having reading vision that is not like what they're used to with their glasses off. It's also, of course, really important to discuss halos. There is argument towards EDOF lenses reducing some phenomena of halos versus trifocal lenses, but you better nail their astigmatism with either of those lenses in order to help minimize that effect. The other thing to note is certain lenses in those categories may do a little bit better job in low light settings. So this is of increased interest. Each of the companies make lenses and have arguments for how a certain lens may function better in low light. Um, so I think, just being upfront with patients about the potential for greater light usage in order to use certain lenses is important too. What about patients with an irregular cornea? So we talked about patients who, maybe form fruus keratoconus or more obvious keratoconus or post-RK. I think these are patients where multifocal optics just simply do not work as well as we would want. So the options of considering a monofocal or a toric are usually the way to go. And we talk about improving vision quality, maybe more important than the range and vision of these patients. One way of thinking about them is they already have multifocal corneas. Why put a multifocal lens? Um, and setting expectations are important too. Important too. I can and have used at light adjustable lenses in some patients like this. If they're post RK, you have to be very clear about the timeline that they're going to need for better vision. So if they're post RK, I wait 3 months to do any adjustments to the light adjustable lens, for instance, and sometimes longer. And that's a long time to wait for cataract surgery in the process of healing from cataract surgery. Now, a lot of those patients have significant cataracts, so the improvement they see simply from removing the cataract and getting a lens in, which is a good estimate of what's best for their eye, is still good, but you need to be very clear about the timeline to better vision with those patients. What are the take-home points? Well, certainly safety in cataract surgery is largely defined by the improvement in fluidics, which all of us have access to, but also technique. That's really the probably even more important, but the systems continue to get better. technology in terms of intraocular lenses in particular need to be very individualized. And I'd say patient selection, expectation setting is really paramount. Intraoperative techniques are situationally powerful. So we've really, I think, nailed today or brought home that message. It's really about how you employ them in certain situations, which are really, really important. I want to make a couple of acknowledgments for research funding that we, both Dr. Lay and I have. And I thank you for your time. We're going to go to my test question again, and let's see if we have any different thoughts. So a reminder, we have this patient with pseudoexfoliation coming to you for cataract surgery. And which of the following statements regarding phacoemulsification fluidics is most correct? Give you a chance to answer that. This is going back to something I talked about early in the talk. So let's see if there's any more unison on what the right answer may be. Potentially impacted by how many people saw the distribution after the first after the first go around too. Yeah, I think that's the right answer. So I think torsional is what really reduces chatter the most, or maybe even the 4D systems. Active fluidics specifically stabilize intraocular pressure, and surge control really is important for the is most important in the densest lenses. So um, yeah, that's great. We will uh, we will now kind of open up discussion to questions from participants. Um, let's see if we have some questions here. We do have a question here. So, I'll read it out to everyone. Thank you, Amanda. What would you say to the patient who is given all the counseling about multifocal lenses prior to surgery, but they choose to go with the monofocal lens to save money? Then after the surgery, they realize they want a multifocal lens and hate wearing reading glasses. How soon after the surgery could they have an adjustment? Yeah, man, I love this question because I think it touches on one of the things that I was kind of hinting at one point. Um, I, you can have displeasure after cataract surgery with any of these lenses, right? You can absolutely put in a monofocal lens in a normal patient and they can have halos. But you could look at all the measurements and you could be convinced that, I mean, this is a great choice. We've been conservative. They want us to be conservative. We put in a lens that we thought is matched perfectly to the aberrations. We picked the MX60E lens, right? We picked the Invista. Minimal aberrations. We should be good, and they can still have problems. By the same token, you can have a patient um, with really bad FOMO, right? You're describing a FOMO patient, right? A fear of missing out. This is a patient who feels like they made a good choice, and they have regret. And I think in some ways these patients are somewhat harder to deal with than the patient who goes for it. And you work through how to handle what to do with them postoperatively after they're multifocal. I mean, I think the most direct answer to your question, how soon after surgery could they have an adjustment, really depends on the type of adjustment you're thinking. I do like to wait a little bit longer to let them heal, let them at least finish their post-operative drops, making sure you've really treated their surface too, and getting at what is the underlying reason for some of their dissatisfaction. Even in this scenario where it feels like their dissatisfaction is specifically just concern over the lens that they may have missed out on, maybe there's something else medically going on that you need to kind of consider treating. Um, and I think in general, I take a very slow approach to doing things like a lens exchange. One of the things that helps me with that is recognizing you can actually get these lenses out well down the road. One of the classic teachings is, man, you better get this lens out in 6 weeks, or you're going to have a lot of trouble getting the haptics out. I will routinely take out lenses if I have to, or if they come to me way down the road with dissatisfaction. You can take them out a lot longer. So I don't think there's a rush. I would say waiting, letting them heal, treating the eye for whatever is potentially contributing to the dissatisfaction is far more important than kind of rushing into it. And that's a challenge too in terms of getting, reassuring patients that more time will make a difference. Um, but that's my approach. Now, do you do anything a little different there? Or?
which is pretty similar. Whether it's a patient who is having issues with the multifocal or vice versa, I typically give them a period so they can sort of adapt to it and get used to it. I'm not a very aggressive surgeon, so if I have a patient who has a complaint about a lens, let's say a few weeks after surgery, I'm usually not going to jump into doing an exchange unless there's something wrong with the lens. Let's say it rotated out of position or a haptic came out of the bag somehow. Um, usually I will just kind of, see the patient regularly, kind of reassure them and try to get them through that neuroadaptation period. If they got a monofocal in their first eye and they haven't had their second eye yet, I mean, there's a couple options to grant them sort of the range of vision. Just because they got a monofocal in one eye doesn't mean they have to get a monofocal in the second eye. So there are a lot of refractive surgeons who will mix and match lenses. An example of that would be giving a patient a monofocal with a distance target in their dominant eye, and then in their non-dominant eye, considering something like an extended depth of focus or a multifocal lens. I think that would be a reasonable option as long as you counsel the patient about getting used to sort of adapting to the multifocal. The other option would be going with monovision. You can give patients a range of vision with a monofocal lens if you do monovision. The tricky thing about that is, making sure they'll be happy with the monovision. So typically, if a patient has never tried monovision, I will have them trial it with contact lenses prior to doing it surgically. So these are some options about how you could help the patient who maybe had, FOMO after getting a monofocal lens in their first eye.
I got another question too about lowest K readings that we would use. I think we certainly see patients with insanely low K readings, particularly after things like RK. Um, I think the RK patient, they just bounce around so much. If they've had 8 cut RK or more and they have super low K readings, I mean, I would say I think of a general threshold for what's super low is less than 38 in my mind, as an average K, depending on what measurement you're using. Certainly, we will see routinely less than 35. Um, I think in those cases, I'm just more conservative, particularly in an RK patient. Their vision just bounces around so much, and the refractive target can be such a moving target that it's tough. Now, if it's a post LASIK specifically patient, I would say for a multifocal lens, I think it's nice to really look at the pattern of the ablation. I think it's nice to really hone in on what Dr. Lay talked about with the total higher order aberrations. Um, I think those patients unfortunately struggle with multifocal lenses, sometimes even if the average K is 40. So um, I think your antenna are up for questioning how much a multifocal lens is going to work in that multifocal cornea, even for Ks, in the 40s sometimes if aberrations are high. Anything less than 40, um, I will generally think about an LAL in that post-LASIK patient, because those lenses still work really well. They're not as prone to decentration. You get to treat the lens and the visual axis that they end up with, rather than having to place the lens in a predicted visual axis and it ends up being a little bit off from where the cornea is. The LAL you get to treat, and they get to determine not only what refractive error they want, but you get to reset their visual axis in a sense basically an alignment of that lens in the eye.
I'm similar. In these patients who are post-refractive laser, whether it's LASIK or PRK, I'm offering LAL in these cases. For similar reasons, one, they often have aberrated corneas. Their K values can be very different from a normal eye. And then sort of the third thing is, our even our modern IOL calculations aren't perfect when it comes to these post-refractive eyes. And if I'm putting a multifocal, I really need to nail sort of that plano target for that lens to perform well and for the patient to be happy. So for me, it's too many uncertain factors. If a patient's paying a sort of premium price and expecting a premium outcome, I'm offering LAL for these cases.
Couple of really good questions too. One is I can't imagine an IOL exchange because patients want something different will be covered by their medical insurance. Yeah, so practical considerations like the cost of an exchange certainly matter, and it obviously depends on who you go to, right? If you go back to the surgeon who did the surgery, um, it's going to be different than going to a new surgeon, and coverage by medical insurance can vary. What about a patient who cannot tolerate multifocal contact lenses? Is that similar? Is that a good estimate of how they may tolerate multifocal IOLs? I would say no. I would say that is not something I really look for. And I would say in general, it really depends more on the cornea. So simply their intolerance of a multifocal contact is actually not, I would say, not a key driver of whether they would tolerate multifocal IOLs. You could certainly, certainly there's some justification for that, but it is different. I think maybe if they're intolerant of a contact lens because their surface is quite irregular and the topography lines up with that, and maybe they have EBMD that needs to be addressed ahead of time, that may be different. Um, so I think that's where we're going to wrap it up. Brian says we've reached our time for this talk. A lot of good questions, and I'm sure we could talk about more. So we really appreciate your time and interest in our talk, and it was great to be with you.
Thank you all for having us. It's been an honor.